Hi, I'm Sarah Trott, and welcome to the Fourth Trimester Podcast. I'm a new mama, and this podcast is all about postpartum care for the first few months following birth, the time period also known as the fourth trimester. My postpartum doula, Esther Gallagher, is my co-host. She's a mother, grandmother, perinatal educator, birth and postpartum care provider. Fourth trimester care, our topic, is about the practical, emotional, and social support parents and baby require. And importantly, it helps set the tone for the continuing journey of parenting. Hi, this is Sarah Trott, and welcome back to the Fourth Trimester Podcast. I'm here with my co-host, Esther Gallagher, and with a special guest, Allie Starling, who I will introduce in a moment. And before I do, I want to remind everyone that we have a website, which is fourthtrimesterpodcast.com, where you can go and sign up for our newsletter, get lots of resources and free downloads, and be alerted every time we release a new episode. And please also do hit follow or subscribe wherever you listen. So Allie is here with us as a guest because we are talking about the concept of finding peace amid perinatal mood and anxiety disorders. So you might hear the phrase PMAD or the acronym PMAD to describe perinatal mood and anxiety disorders. We're going to talk about weathering that storm and finding peace. So Allie is such a great guest for us on this topic in particular. She is the assistant professor in the Division of Maternal and Fetal Medicine at UCSF, which is the University of California, San Francisco. So prior to joining academia, she practiced for many years in the Southwest, both in Arizona and in New Mexico. And she's also spent time working as a midwife for Doctors Without Borders. And her passion for the peripartum mental health journey began a long time ago when she realized that there was a lack of providers that felt really comfortable working with patients in the realm of peripartum psychiatry, mental health. And also she discovered the unique partnership that midwives can offer in this space for their clients. She is originally from Wisconsin, and she loves living on the West Coast, most notably due to the mountains. So she has a newborn herself, which keeps her very busy. And when she's not with her newborn or traveling with her partner, you can find her hiking and trail running in the mountains, which sounds very lovely indeed. So welcome to the show, Allie.
Thank you. Thank you very much for having me.
Yes. We would love to hear an introduction in your own words.
Sure. Well, I think you hit most of the salient points. I've been a midwife for about 9 years. I trained at UCSF, and now I'm back in the San Francisco community. I do work at UCSF in the Division of Maternal and Fetal Medicine. And then, like you said, I started my career working for Indian Health Services in northern Arizona and Albuquerque, New Mexico. I was a sexual assault nurse for a few years and also have done stints in north of the Arctic Circle in Alaska, working also for Indian Health Services north of the Arctic Circle. So I am passionate about midwifery and mental health and the intersection between the two. So I really love this topic and I'm happy to be here.
Yeah, welcome. And you're also a parent yourself. And on the show, we have a tradition of talking about our own fourth trimester experiences. And we'd love to hear more from you about yours.
Yeah, this topic is very true and near and to my heart for many reasons. One of them being because I'm a new parent myself. I have about a 7.5-month baby. And my fourth trimester started off very unexpected and rocky. My bag of water broke when I was 32 weeks. And then I was hospitalized for a few weeks and was induced at 34 weeks. So all of a sudden, my many years delivering babies and being a midwife and providing prenatal and postpartum care came to a very unexpected halt and veered. And just like any labor and delivery, I experienced something that I couldn't plan for and something very unexpected. So, I was hospitalized, induced at 34 weeks. My baby was in the NICU or the ICN for about 2 weeks. So that was a very trying experience for my partner and myself. And the fourth trimester is hard, joyful, challenging for everyone. And when you have a baby that is unexpectedly, or even sometimes expectedly in the NICU, it makes the fourth trimester even start on a even more trying and rocky beginning, because you are shuffling back and forth to the NICU or the ICN. You are away from your baby. You are not able to do skin to skin. You are not able to sleep near your baby. And most NICUs are not very maternal or parent friendly. So it makes the fourth trimester pretty challenging to start off with, but luckily things have somewhat smoothed out since then.
I'm glad to hear that it has smoothed out since then. And I'm sorry that that was a challenging time.
Yeah. And, and I'll talk about this later in the podcast, but oftentimes people who do have higher risk deliveries, higher risk births, higher risk or maybe poorer outcomes for either the mom or the neonate are at a higher risk for having a postpartum mood and anxiety disorder or having PTSD or trauma postpartum as well. So I think, met the criteria for some of those instances because I had a higher risk delivery and definitely had to experience things that I had, no intention of obviously experiencing, but you can never plan for labor and delivery 100%. So it was a really humbling experience and one that my partner and I weathered through.
Yeah, that's a lot to go through. And you definitely mentioned the word intentions, and I appreciate that. We have a birth plan template, which we call a birth intentions template. That's a free download on our site for anyone interested. But the word intentions is really helpful in part just because, it's useful to think through what you may or may not want to happen as an experience. But as you're highlighting, it's very unpredictable to a degree. Had you at 34 weeks, given your line of work, I imagine you thought it through significantly, but had you put pen to paper for anything at that point?
Being a midwife and in the birthing world, delivering babies for over 10 years, I never really wanted to have a birth plan or birth preferences because I've seen so many scenarios. And I like to tell a lot of my patients or clients that in some ways, the best plan in labor and delivery is to not have a plan because you never know what's going to happen. And I find that, not always, but I think it's good to have intentions, but also be open to the fact that sometimes things don't happen the way that you expect them to or want them to or intend them to. And because I work in a space that is higher risk, I'm at a hospital as a midwife, I've seen a lot of different scenarios play out and a lot of different expectations in the birthing world that haven't been met. And I think that I started preparing for my fourth trimester when I was about 25-ish weeks because I've seen so many different scenarios and people who haven't necessarily prepared for their fourth trimester. And so I really try to recommend my patients to start preparing when they're between 20 and 30 weeks, because things can happen that you don't expect. And I think it's better to be a little bit prepared, whether that's just getting a registry ready, preparing your apartment or house with certain supplies, getting your bottles ready, your breast pump ordered, various things like that, because you really don't know what's going to happen. And I think being prepared for the fourth trimester earlier on the earlier side is my recommendation.
Yeah, for sure. And sometimes the benefit of having a plan is not because it's going to go the way you want, but sometimes just doing the research and learning. Given your line of work, you're a professional in the space, so you really understand the language and the words and the possibilities at a very deep level. But for people who are not in the space, sometimes the benefit is really just understanding what could happen, learning some of the language, learning what the options are so that they're informed, at least going into it. But having the mindset of preparing early, love that. And love the whole point about, it's not necessarily going to go the way you want. And your experience is an example. But another thing you did, you prepared in advance. I think you mentioned something when we were doing our prep about medication that you thought through.
Yeah. One of the many reasons that I enjoy this topic is because I myself have a diagnosis of an anxiety disorder, which is pretty common in my age group and in the postpartum period as well. But one thing that I did was I went up on my medication when I neared the third trimester. And that is oftentimes a recommendation that we give certain people who take certain medications in labor and delivery and prenatally as well, just because there's so many physiological changes that happen when you're pregnant. So when you start, especially nearing towards the end of the second and start of the third trimester around 28 weeks, one of the main changes is huge plasma volume increases. So the volume of blood, fluid in your body increases. Pregnant people they just hold a lot more fluid. So if you think about that, your medications will become diluted in your system. So that's why oftentimes most conditions in pregnancy, whether that's diabetes or high blood pressure or whatnot, we recommend to go up on the medications in the third trimester. So I recall when I was nearing my third trimester, I at one point had a mild panic issue, and I was like, I think it's about time to go up on my medications. And so I did. And I think it really, really helped with me for the rest of my pregnancy and my postpartum period as well. So that's something that I did. Like I said, it's not for everyone, but it's usually recommended oftentimes in the psychiatric world.
Mm-hmm. And some people will think that they would reduce or come off of anything. I know, like I stopped drinking caffeine as a personal choice and certain things like that. Like I was very cautious about what my body was taking in nutritionally or whatever else. And so it may be counterintuitive to hear that. But if you're working with a professional who knows that the medication is safe for your pregnancy, and that's the recommendation, then it sounds like the right thing to do, obviously, is to follow your advice from your medical team.
And Allie, since we have you using yourself as your own example, can you speak to how things were able to shift for you by way of getting those meds and availing yourself of them?
Yeah. So I think that what I notice and what I think a lot of pregnant people notice is that there are a lot of these expectations that, you're preparing for birth. Many of us are still working full time. We are living in very somewhat stressful environments, urban environments, commuting to work, working long hours. And, I'm living in a 1-bedroom apartment with my partner, and we were looking at moving and looking at, preparing for baby. And it just got to be too much. I was overwhelmed, woke up in the middle of the night and had some symptoms of a panic attack, which I hadn't had for many, many years. And I realized that to me, it was not worth it to move. It wasn't worth it to have more panic attacks. It wasn't worth it to be anxious and stressed. And the medication that I had been on for many years, at that time, my body was changing. It was becoming more dilute. And the medications were not working as well as they would have when I wasn't pregnant and had my pre-pregnancy body. And so I noticed that by going up on my medication, it sort of brought down my threshold for stress, my threshold for anxiety. And I didn't have any other panic symptoms the rest of my pregnancy. But it's different for everyone. That's for sure. But I think that one point that, and I'll make it later too, is that, there's all these societal expectations. You need to move to a bigger apartment or move to a bigger house or, buy a car that is better for baby. And you really can't do it all. You can't, especially when you're working full time. So I think that preparing as much as you can, but just realizing there's no way to get it all done.
Yeah. I also think that for a lot of us, somehow we're expected in the third trimester to get it all together and get organized. But the thing is that so much is coming at us that getting organized, we just become overwhelmed and therefore can't get organized around the basics. And the basics, in my opinion, and I've said many times on the podcast, are making sure you're not anemic, making sure your blood's healthy before you go into labor and birth and breastfeeding. And, we're having prenatals that are coming at us that are very baby focused, but it's my experience as a longtime caregiver, support giver, that women's health in the third trimester is starting to gradually erode. because no one's telling them it's time to slow down. It's time to rest. It's time to make sure you're not anemic. It's time to get enough sleep, and you're only going to get it if you sleep during the day. And of course, Sarah knows, I know, if you're working full time, no one's letting you take naps. It's just a nut job situation, right? So if your mental health is even just a little bit disorganizing, is the word I use. It's ordinary, normal confusion, but the volume's been turned up because of your situation and potentially your past history with mental health. And I personally think it's a miracle that any of us get to childbearing age and aren't already anxiety disordered in this culture. So if meds are going to be the thing that just helps you drop down into a slightly more organized body and presence for yourself, then, it's sad to me that women strongly resist taking medication when they're about to be crashing into the wave head on of all the things, right? Late pregnancy, early motherhood that isn't complicated. I'm speaking about myself now, can be very, very anxiety provoking. So whatever it takes to just not feel like you're right on the edge, every breathing moment would be a boon. Yeah. So thank you. That's why I'm thanking you for showing up here. I've got decades of experience with this. Motherhood doesn't get easier in the fourth trimester. It just doesn't. It takes a while. So going into it under-resourced is never what we want for moms on this podcast. So thank you.
Yeah. And, I appreciated, Esther, how you said third trimester is a time to slow down. I'm a ultra marathon runner, and it was very hard for me to slow down. And many of my patients have asked me about certain things that they did pre-pregnancy, and now what do they recommend pregnancy, and things such as running, etc. And I think you should follow your heart, follow what your body says. And if it's healthy for you and your healthcare professional says it's okay, do it. And in general, your body has to sort of slow down when you're pregnant, because these hormones of pregnancy, such as progesterone, do slow your blood volume down, slows your GI system down. And it is a really good time to prepare in the third trimester for the fourth trimester. So I appreciated you saying that.
Yeah, your baby doesn't have time for you to be running ultra marathons in the fourth trimester.
And then I wanted to say that, just to continue to decrease the stigma about mental health issues, according to the American College of Obstetricians and Gynecologists, this is a pretty large range, but 5 to 40% of birthing people postpartum meet some sort of criteria for anxiety. And about 1 in 7 meet some sort of criteria for postpartum depression. And then there's an 80% comorbidity, so a combination of both anxiety and depression in the fourth trimester or the postpartum period. So I just want to say how common fourth trimester mental health conditions are. And one of my goals is to decrease the stigma, and I want people to talk about it. I want people to reach out for help, and I want people to know that there is help out there if you need. And yeah, there are resources out there.
We've talked a lot on the podcast about non-pharmaceutical approaches. In fact, we just did a chat about that, and we talked about mindfulness-based stress reduction. We talked about somatic experiencing for PTSD or other trauma bodies, and we talked about the nervous system and regulation and all those things. And we're happy to talk about them with you again, of course, no problem. But are you willing to do a little bit of a dive into what is considered safe and pharmaceutically these days, and how these work and the physiology of them?
Sure. And I just want to say that in general, most psychiatric mental health providers would say that for mild psychiatric disorders, or even some moderate psychiatric disorders, so if you meet the criteria for whether that's anxiety or depression or postpartum, you can treat them and you can get solace and relief with non-pharmacological means. Definitely. And so I love it how you're really focusing, and you've talked a lot about non-pharmacological relief, because that is by and large how most people improve. If you don't have a debilitating issue, if you're able to function fine, and you might just have mild anxiety or mild postpartum depression, you probably don't need medication. And you probably would be fine with talk therapy or mindfulness or changing your diet or other means. But it's when you cross that threshold and you get into the moderate to severe postpartum depression, moderate to severe postpartum anxiety, and then definitely if you have a criteria for, obviously postpartum psychosis or something that it's a little bit more, definitely more acute, is when most research and evidence would say we definitely recommend medication at that point. So yeah, I really appreciate that you've talked a lot about non-pharmacological means. So yeah, so medications can be really, really helpful, and they're not helpful for everyone. And a lot of people don't want to take medications, and that's 100% your choice, right? Just like anything in life, you are in charge of your body, and it's your choice whether or not you want to take medications. So it's up to you and your healthcare practitioner to use shared decision making, and your healthcare practitioner to really go through the risks and the benefits of every single medication that they recommend to you. But I do want to say that similar, like I already mentioned, if you had diabetes, your healthcare practitioner would probably highly recommend you to take insulin. If you had high blood pressure or postpartum high blood pressure, your healthcare practitioner would probably definitely recommend you to take some sort of antihypertension medication. If you had a blood clotting disorder or a DVT, especially postpartum, your healthcare practitioner would probably highly recommend you to take an anti-clotting medication. If you had, and the list goes on, right? An immune condition, anything. And so medication for mental health conditions is the same. There's a reason they exist. There's a reason that they've been made. And there's a reason that we would highly recommend to take them as well. So I want to just let people know that if you are recommended to take them, it's okay. And millions of people are on pharmacological medications for various conditions.
And there's no stigma around a blood thinner. There's no stigma around some of these other medications that are so common. So why feel bad? It's not your fault. It's not anyone's fault.
Exactly. Or asthma, being on an asthma medication. So yeah, I'll just do a quick and dirty talk about what are the most common medications that we recommend. By and large, for PMADs or perinatal mood and anxiety disorders, I'm sure most all of us have heard about SSRIs or serotonin selective reuptake inhibitors, which are not so selective actually, meaning they have various side effects. So most of the time, if people do not have a history of mania or bipolar disorder in their family or themselves, we would recommend an SSRI postpartum or prenatally if they do meet the criteria for a moderate or severe anxiety disorder or depressive disorder. The two most common are sertraline or Zoloft or Lexapro, escitalopram, which are also two of the most common medications that we prescribe in the non-pregnant population as well. So these two medications, I would say by and large, are the most common. There are side effects involved, like with every medication. You've all probably heard of some of the side effects. Very commonly short term, it's like GI issues, nausea, vomiting, headaches. Long term, there might be, some people say there's weight gain. Sometimes there's sexual issues, inability to orgasm. Everyone's different. So there definitely are side effects. Some people say they lead to emotional blunting. Sometimes they lead to some restlessness or insomnia. So ideally, if you do meet the criteria, your healthcare practitioner would go through all of the side effects of the medications and then go through all the benefits of the medications. And so one of the reasons it's so important to treat mental health conditions in pregnancy and postpartum are for the newborn health as well, and for the mom's health or the parent's health. If you don't get treated, the fetus or the baby is still exposed to the illness. So there's an exposure to everything. There's either the fetus or the newborn is exposed to the medications, potentially a little bit through the breast milk or a little bit through the placenta, or the fetus or the newborn is exposed to the birthing parent being ill or the birthing parent having a postpartum condition. So both, there's always an exposure. So the fetus or the newborn that's exposed to a birthing parent that has anxiety or depression, there have been studies that show there's less ability to bond with the birthing person. There's less rates of breastfeeding with the birthing person. There's less rates of the newborn going to preventative care visits, increased rates of the emergency department usage. There's more difficulty attaching to the caregiver, increased rates of ADHD, and increased rates long terms of things like anxiety and depression and in the newborn. So there's definitely many reasons to get treatment when you are a new birthing person or when you're pregnant. And when you're pregnant, there's increased rates of preterm birth, increased rates of low birth weight, and increased rates of high blood pressures if you're not treated for perinatal mood and anxiety disorders. And then obviously, more acute issues, if you're not treated, definitely worst case scenario, increased rates of suicide and homicide for conditions that aren't treated, and then increased rates of substance abuse too. So for people who aren't treated, it leads to higher rates of substance abuse.
Can I just butt in here real quick and say, I don't want anyone who's listening currently to assume that we're only ever talking about moms here, biological women carrying fetuses. Yes, in terms of what you're talking about physiologically, exposures in the womb of whoever's womb you're in are a real thing, right? It's either cortisol or, whatever hormones we're shooting off as a result of our anxiety. But we know for a fact that it's no small thing that there's a significant proportion of male-bodied people who living in the perinatal space are experiencing anxiety and depression. They act it out differently most of the time. And that's one of the reasons why postpartum women are at extremely high risk for homicide. If you're a male-bodied person in the perinatal space and you're experiencing distress, it's imperative, just like for the rest of us, that you be seen and attend to your mental health. So just had to make a bit stop there.
No, thank you, Esther. And not just for people who are male either, just anyone that has a newborn. So whether you fostering a newborn, adopting a newborn, or a non-biological parent, definitely, undoubtedly. So I really appreciate you bringing that up. Anyway, so do you all have any questions about sort of what I was talking about with the risks and benefits of being on medications?
I'm curious, when it comes to SSRIs, so many of the symptoms that you mentioned of like taking the drug sound to me like symptoms of having depression, right? Like I'm always curious, like, is that just part of the transition through the onset of the drug starting to work and then those symptoms relieve? We talked about physical symptoms like nausea, eating, maybe an increased appetite or just weight gain, and the headaches. And so I'm curious, I have a family member who was treated with them and then became manic.
Yeah, no, definitely. And that's why I mentioned it's important, and the American College of Obstetricians and Gynecologists recommends to screen everyone prenatally and postpartum for anxiety, depression, and bipolar disorder, because you definitely want to Make sure that no one has manic signs and symptoms, meaning if you've ever experienced a time in your life that you have been so wired that you haven't needed to sleep for 4 to 7 days at a time and done sort of reckless activities or engaged in, things such as like shoplifting, overspending, extreme drug use, sexual promiscuity, etc. There's a huge list. And or if you have a family history of mania or bipolar disorder, you might be a little bit more cautious when you prescribe an SSRI, undoubtedly. So thank you for bringing that point up again.
And this would also be a good reason, if you're going to go this route, you want to really find a support system that will keep you in touch with your psychiatric team, because if you start to go off the rails, you're not necessarily the person who's best equipped to, apply yourself to the project of getting seen and adjusted, so to speak. Yeah.
Yeah, I just wanted to quickly, one thing that I see with my patients is that, there's a stigma around certain mental health conditions, and there's a stigma around not wanting to be on these medications for breastfeeding. And I think hopefully some of the myths surrounding psychiatric medications with breastfeeding have been increasingly debunked in our common literature and society, but most medications are safe for breastfeeding. There are some rare exceptions, but it's definitely worth it to talk with your healthcare provider about the psychiatric medications you're on, or any medications that you're on for that matter, whether it be a medication for asthma or a medication for high blood pressure, to ensure. But most are okay with breastfeeding, and I think that and if they're not, then you can make that decision with your healthcare team that maybe it wouldn't be safe to breastfeed or pump or express your milk for your infant, and do some other means of feeding.
And that's true for pregnancy as well. Is that right?
For medications? Yeah, definitely. And so, I mentioned SSRIs, but there are many other medications that people take for anxiety, depression, OCD, obsessive compulsive disorder, panic disorder. There's a plethora of medications out there. And most medications, if you're on something and you're stable in pregnancy, most of the time your healthcare provider will tell you to stay on that medication. Yes, there are exceptions. So like I said, it's important to talk to your healthcare provider. Certain medications, there's simply not that much data on them. The FDA is slow to approve and do studies. Obviously, it's hard to do studies on pregnant people and postpartum people because it's unethical. But just because there's not data and studies, evidence, doesn't mean necessarily that it's unsafe. That's similar with supplements, right? There's a lot of supplements out there that don't have the FDA approval for anxiety, depression, etc. But that doesn't mean that we take them every day and that they're not safe. So it's important to have that conversation with your healthcare provider. So for instance, if you're on a very common antidepressant medication called bupropion or Wellbutrin, or you're on a common medication called duloxetine or Cymbalta, that's just an SNRI. That doesn't mean that just because you're not on sertraline or Lexapro, you can't stay on that medication because you've had success with that medication. And in fact, most of the time, your healthcare provider will want you to go up or recommend to go up on that medication, like I already mentioned, in the third trimester to meet the physiological demand of the third trimester. And then that'll probably help in the fourth trimester as well. But fourth trimester is interesting from a physiological perspective because oftentimes your demands for medications will decrease, but that'll be something that you will work with your healthcare team.
Yeah, that makes sense. And then the question that I had for you about the side effects, I mean, that can sound really off-putting. Like, who wants to have that laundry list? It was like a woman, I just trading one set of things for another, right? But I'm curious to know, just because it's a potential side effect, it doesn't mean that that applies to everybody. Like, each person is different and they may or may not have those side effects, right?
Yeah, 100%. Every drug affects everyone differently. It's like when in labor, when I'm working with laboring patients, there's all these myths and fears around Pitocin, which is the most common medication that we give for people in labor. People have really strong feelings about Pitocin with reason. And oftentimes people are okay with it. They do fine with it. or birth control. Every person's body reacts differently to various types of birth control. I loved my Mirena IUD. I had it for, I had two different one. It worked great for my body, but I have so many friends and colleagues that would totally swear off the IUDs, swear off Mirena IUDs, because they say the hormones affect their body. Everyone reacts differently to medications. And so it's really up to you to let your healthcare provider know and work with them. And there are medications that you can take for side effects too. So if you have dry mouth, if you're sweating a lot postpartum due to your medication, which postpartum people oftentimes do sweat anyway, there are medications you can take. Or some people have had sexual side effects with certain psychiatric medications. There are medications you could take for that too. So that's a very good point, Sarah.
Thank you. Thank you for clarifying that. And so we were going to also talk about some of the non-medical approaches.
Yeah. So please feel free to chime in, because I know that you all have talked about this a lot. But I think that, like I wanted to say already, I think preparation is really important. Preparation in the second and third trimester for labor and delivery and the fourth trimester can help decrease your threshold for a postpartum condition. So decreasing obviously, if you're using substances, decreasing that, working on, if you have, for instance, if you've had trauma before, like trauma with a previous birth or a poor birth outcome, poor birth experience, working with a psychologist or a mental health provider to help decrease the trauma response that you might have going into the next birth and prepare for the fourth trimester. If you have a previous history of postpartum anxiety and mood disorder, help preparing with medication and or preparing your social support and your social team for the next postpartum experience to try to prevent it from happening again. I find that my patients who do have experiences, maybe not the best fourth trimester experiences, if they prepare the next time around, they usually have a better experience. So it's really fun to watch and to see that preparation can be key for a lot of people that have a history of maybe not the best the fourth trimester experience. So I already mentioned therapy, psychosocial therapy, talk therapy, and important to really let your therapist know, or your talk therapist, there's so many different types of therapy. And so not just to have a therapist who's like acts as a friend, but to have a therapist that really can specialize and hone in on exactly what you need. So yeah, if you do have a history of trauma, someone that works in EMDR or rapid eye desensitization or exposure therapy that can really hone into exactly what you need. And social support obviously is key in our day and age when we are very isolated, COVID notwithstanding. COVID's hopefully going down, although I saw headlines that maybe the rates are increasing, to have that social support in the second and third trimester and start building it. So whether that's a meal train or whether that's having people visit you before you give birth and have this social network before can be really helpful postpartum. If you guys want to chime in too, feel free. I know that in your podcast, you've had guests before that have talked about the importance of sleep. Sleep is medicine, just like food is medicine. And so there is postpartum insomnia, and third trimester insomnia is a huge issue. So working with your healthcare team, there are medications you can take for sleep too. So if you are to the point in your fourth trimester journey that you cannot sleep, you can't sleep when the baby's sleeping, you are only getting a few hours of sleep a night or a few hours of sleep during the 24-hour period, there are definitely ways to improve upon that. And I know we're supposed to be talking about non-medical ways, but there are medical ways to improve your sleep as well. Exercise, getting outside, vitamin D, getting sunlight is tantamount to feeling well. If you're living in an environment where it's cold weather, you might have seasonal affective disorder, getting a heat lamp or getting some sort of lamp to help give you more light can be really important. And ecotherapy, there's been more increasing literature about the importance of getting out in nature, getting away from the concrete jungle can be very important.
We did a podcast a while back with Riza Tanner, who does these wonderful moms groups called Wild Return, and it's all about getting together with babes and getting out in nature and talking it out and all the things. So
Yeah, no, it's so important. And it's hard in an urban environment too. And many of us with a newborn don't want to drive or don't have somebody that can drive us, and you're home alone, and just getting out into your urban environment can be scary sometimes. So
I will say that one of the ways one can prepare, if you already know that you're living in an environment that you've found intimidating, shall we say, learning the public transportation system so that you are not isolated. Just learn it, practice it a couple of times, going to places that are going to help you feel fine. In San Francisco, plenty of buses get you within spitting distance of Golden Gate Park. So as an example, right, learning these things, people who are reliant on car culture that don't have cars, it's a mental health game to shift your perspective on that and not feel isolated. And if you do live in a concrete jungle, you probably also live where there might be public transportation of some sort.
Mm-hmm. No, that's a great point. All about preparation. And then one thing that I wanted to chime in there is that we do spend a lot of time on our phones. You can probably look in every major news media outlet about how we're spending too much time on social media. And so, I chose when I was pregnant for my New Year's resolution, I believe I chose to get rid of social media. It's brought more joy to my life. I'm not saying it's going to bring joy to everyone's life by getting off of social media, but there have been, increasing studies that show that we do spend too much time on our phones and do spend too much time scrolling through Instagram and TikTok, etc. So that's a suggestion that some people find helpful.
I'll piggyback on that one and say, you could stop watching the news and nothing bad would happen. You could just stop because there's nothing you're doing about it. You're riling up your nervous system. And in some cases, people are doing it from the time they get up until the time they go to bed. And it's mostly all bad. And then you're carrying that around, not doing anything about it except somatizing it. So I always think it's a really smart idea to not wait until you can afford a yoga retreat, but to just take a break from it. Just take fast from the news. You don't have to know all that stuff. Nothing bad will happen. Only good things will happen if you stop listening to the news. I promise.
Yeah, that's great. And you mentioned mindfulness before, and just how sometimes in our fast-paced culture we don't take time just to sit, and when we're breastfeeding or however we're feeding our newborns, just looking at their eyes instead of looking at our phone. I had to triple feed for 2.5 months, which means I got an hour of sleep chunks for about 3 months almost. And it was so hard not to scroll on my phone when I was doing that. But I think your newborn will feel more attached and the bonding connection will be better. You will produce natural oxytocin more if you aren't looking on your phone in the news and actually looking at your baby and bonding with your baby.
And less cortisol, right? Because news is cortisol. Babies are oxytocin. Take your pick. Cortisol doesn't do anything good for you unless there's a tiger in the room, right? Then it might be helpful.
Yeah. Well, and I like to tell new parents and even prenatal patients that some cortisol can be a good thing. So some anxiety is a good thing. Because if we didn't have any anxiety, we'd be sitting on the couch watching TV all day, not working and not caring. So I think some anxiety can get us to be proactive. Some anxiety can get us to care. It's normal to be anxious as a new parent. It's normal to be worried about your new baby or your new family. But when you reach that threshold where your worrying is coming to become non-functional, and when your worrying is to the point where you can't take care of yourself and you can't take care of your baby, that's when you really need to seek help, medication, and definitely unmedicated ways, but medication as well can be extremely helpful.
I've heard people refer to some of that as interruptive thoughts.
Intrusive.
So like intrusive thoughts, right? Where you're you can't stop thinking about the anxiety. You're trying to focus on something else, but it keeps popping up. Does that ring true? Is that like a good signal to reach out for help?
Yeah, intrusive thoughts is definitely can be a sign of like fourth trimester postpartum OCD, for instance, or anxiety, rumination. So thoughts that are just like circling, asking my patients before, people who are afraid that their baby isn't breathing. And so every 5 minutes are having to check to make sure that their baby's breathing, or being afraid that they're going to drop their baby, or being afraid that they're not taking care of their baby well. Yeah, definitely, Sarah. These thoughts that you feel like you're out of control, these thoughts are controlling yourself. That can definitely be a sign.
I mean, I had all of those thoughts. I think the difference was the distinction here is like thinking about it constantly, or having it be something that's too much of a distraction to actually live your life.
Exactly. Yeah. You were able to function, I assume. But sometimes if you're crying all day, every day, or just not experiencing any joy with your newborn, that's a problem, right? Newborns are extremely hard, but they also bring joy. And if you're not having any joy whatsoever and have other symptoms, that might be a key to seek help.
And I'm going to add in anger, which is the one we'd never talk about. But if everything's making you angry all the time and concomitantly you're not experiencing joy, that may be the way your manifests as, everything seems to make you angry. You're blaming and shaming everything around you because you just feel crap all the time, and you got to find a way to kind of express it. And it's not that you should never feel angry. Again, cortisol is sometimes a good thing, and an angry moment is appropriate when things need to change. But if it's just nonstop, and especially if it's escalating into abusiveness, then that's a problem for everybody involved. So.
You mentioned eating. Was there something you were going to talk about as it relates to certain kinds of foods that might be beneficial or helpful?
Well, yeah, I mean, I think in the fourth trimester period, it's a time to indulge in yourself too, if you can. And food can bring joy, just like a newborn can bring joy. And that's actually a sign of depression, is if you don't have an appetite or eating too much, an atypical sign. But finding joy and eating things, and realizing that, especially if you're sitting breastfeeding and or feeding your baby for hours a day, which is your main job, it's important to have some sort of small bouts of joy during the day. So I think it's a time to have people cook meals for you if you have the means to have people to eat what you want. It's probably not a good time to go on certain types of diets and be worried about what you look like. So I recall when I was in the immediate postpartum experience, I would eat lactation cookies every day. I had it sort of still hasn't changed, but I would have 4 or 5 really juicy lactation cookies loaded with a bunch of great galactagogues and chocolate every day. And I would have a non-alcoholic beer maybe every other day, which is also in some cultures considered a galactagogue, and mother's milk tea. So eating things that bring you joy, I think is important in the fourth trimester. And then there's, some research and data about things such as like flavonoids. I don't know if you've heard of those before, but things like that are found in berries and nutrient anti-inflammatory foods in the postpartum period can be really helpful and boost up your immune system and boost up your postpartum experience. So yeah, flavonoids, berries, occasionally, depending on red wine is something. I don't know if I would necessarily very occasionally have a glass of red wine in the fourth trimester, or definitely dark chocolate in the fourth trimester can be helpful. Doesn't hurt.
Yeah, thank you. And so if someone is wanting to invest in some of these non-medical approaches, it's not an either or, it's an and. Like there's talk therapy and getting social support and getting your sleep and exercise. All of these things are considerations together, right?
Yeah. And then just know that there is light at the end of the tunnel. The fourth trimester, it ends. I think I'm still in it right now, but it'll end, and it will, your sleep will improve. Your body will get back to its pre-pregnancy state. And if it doesn't, that's okay too. There's so much joy having a newborn. There's so much happiness and giggles and laughing and bonding and so much oxytocin flowing. But then it also is very hard. And so just to have those two mindsets is important.
Yeah. Thank you. I like your point about social support too, in part just because we had Jane Honigman on our program a couple of times, and she's one of the founders of Postpartum Support International. I remember we quoted her. I mean, she said, the number one thing parents need is to talk and have that social connection. So whether that's creating a parent group or finding one, we've talked a lot about that on the show with Rebecca Walsh, or if it's about a listening partnership. I mean, you don't really have to pay money for this. I know there are paid groups online, but I don't think you have to spend any money to find someone who's trusted either through a parent group or an existing friend who's trusted to be able to talk with you and listen without judgment. It's so valuable.
Yeah, totally. And yeah, I agree. I mean, there are lots of groups out there to pay for, but most hospitals, whether it's UCS or in the Bay Area, whether it's UCSF or Sutter or Kaiser, have groups that are already formed too, or Highland, that you can join postpartum that are free. And yeah, so I totally agree with you. It's really important.
Allie, this might help you a little bit. You just mentioned that you feel like you're still in the fourth trimester a little bit. When I was doing home birth midwifery, we were having a class and we were talking about postpartum, and somebody asked, how long does the postpartum period last? And I just was like right there with, till your kid goes to kindergarten. Like, as long as it's all on you, you're postpartum. When somebody else starts to be able to, get that kid out in the world a little bit and off of you, then it feels a lot lighter in some ways. So I think it might be normalizing for breastfeeders to understand that, your whole physiology is different as long as you are breastfeeding in some way. And so just to understand, again, it's just a different body hormonally, which is not to say somebody who, for whatever reason, wasn't breast or chest feeding wouldn't also have similar experiences if they're 24/7, kind of first responder for a child. So yeah, there's a lot to having children under the age of go to school.
Mm-hmm. No, definitely. And something that, for instance, I was at, I 7 months postpartum, but I got my period when I was like 3 months postpartum. And I was like, what? This is so unfair. I'm exclusively breastfeeding. Now I'm leaking fluids through all of my orifices. And, it's something that we don't talk about. I'm a midwife, and I realized how hard it is to manage many orifices in my body at once. They say, oh yeah, if you're exclusively breastfeeding, 95% likelihood of not getting your period in 6 months. But I got it at month 3 or 2.5. So
with triple feeding, how fair is that?
Yeah. Anyway, just lots that is not talked about in our society with postpartum.
Yeah. I mean, I feel very fortunate. Again, I say it often enough on the podcast that my perinatal care from start to finish was home birth midwifery perinatal care. And we talked about all of it, and midwives who'd had children would tell their funny stories about being a breastfeeding person at the grocery store when their milk lets down. And it engaged kind of a sense of humor. Like, who knew our bodies would do these crazy things when we're least expecting it? And that was very, very helpful to me. And I was quite young when that started. So I had, lots of run out room. It wasn't hitting me in my 30s where I'd learned to be very proper. I was a rebellious teenager, so it was great. I was like, great, bring it on. When everything's treated clinically, and there too much gets left out, and which is why I'm so thrilled to see midwifery creeping into the more clinical parts of our culture. Really excited by that.
Mm-hmm. Yeah, I mean, I think that ideally every patient or person deserves a midwife when they are laboring, even if they're high risk or have to give birth in a hospital.
I would even say especially. I mean, if you're just going to squirt a baby out, who do you need really? But and I don't mean to be cavalier, but we all need midwives, right? We all should get midwives.
Yeah, and I think in the fourth trimester, even so, just a mental health midwife, someone to check in on you that has some sort of clinical experience, I think is very pivotal as well, because it is so common. Perinatal mood and anxiety disorders are so common. And so, hopefully at UCSF and other places will pave the way for this to happen and nationally as well.
Well, certainly we see some progress being made, and we hope that this conversation is listened to far and wide and helps with that effort. Is there anything else that you wanted to touch on?
Yeah, I mean, I guess I just, since I'm passionate about perinatal mood and anxiety disorders, and I realize how when somebody does have a mental illness, how it affects everything else in their body too. It affects their resilience. It affects their ability to cope. It affects their attitude and their mood, and it affects their functioning, right? So even what I find fascinating is you have patients at high risk birthing centers or high risk patients who are so optimistic and have such fantastic mental health and are thriving, even though they have stage 3 breast cancer and are 32 weeks pregnant, or have pre-E with severe features and have to be hospitalized at 30 weeks, or go into labor at 29 weeks, or to have a birth that they weren't expected, a poor outcome. And it's mental health that really helps pull them to get through these really trying conditions. So, Esther, when you mentioned at the beginning of the podcast how we all in the postpartum period go through ups and downs, like postpartum blues is like 80% of people will experience postpartum blues. I recall when I was 3 days postpartum being in the NICU and they were kicking my mom out at 8 p.m. And I was like, I cannot believe you were kicking my mom out at 8 p.m., crying, my milk wasn't coming in, horrible experience. I was like, this is how we're treating our maternal infant dyad. I can't even have a support person in the NICU. It was absolutely atrocious. But anyway, going back to your point, if you have a pre-existing condition, a pre-existing mental health condition, it can make this postpartum period that we already know has so many ups and downs even worse and even harder. I just want to say that you're going to be okay. There's support out there, and you're not alone if you do have one of the many psychiatric or mental health conditions. And there's help out there if you need, and it'll really help you get through intrapartum, so labor and delivery, which can be very stressful and joyful and scary. And it'll help you get through the postpartum period as well. So, and then you had mentioned postpartum psychosis. I didn't really want to focus too much on postpartum psychosis just because it is pretty rare for it to happen, but we do hear about it in the news quite a bit. Every once in a while, there's like a news article about postpartum psychosis. But in general, ways to prevent postpartum psychosis are just like ways that I already mentioned to prepare for postpartum anxiety or to prepare for postpartum depression. A lot of it's preparation. And if you are predisposed to mental illness and you are on medications, I don't recommend to get off your medications when you are pregnant. I recommend to stay on your medications and work with a healthcare professional that will be with you throughout your pregnancy and postpartum period. Especially if you have a condition like bipolar disorder, if you've been diagnosed with bipolar disorder or schizophrenia or certain healthcare conditions, I definitely recommend to stay on those medications. And then prepare for things such as sleep, prepare for social support, prepare for a lot of different scenarios. And that'll help, hopefully prevent that threshold into postpartum psychosis. But that being said, there are some things you can't prepare for, and there are conditions that happen no matter what you do. But definitely there are ways that you can think ahead.
For sure. Thank you. We love to point people towards resources if someone's listening and they feel like they would like to either find out more or reach out for help somewhere. Are there any resources that you would like to mention in particular?
Yeah, sure. I mean, and maybe I could put these on your website as well. Massachusetts General Hospital has a really good Center for Women's Health that has a lot of, has like a curriculum for perinatal psychiatry that is well researched and referenced center and documents that will be on your website. Mother to Baby organization has loads of handouts and resources for people in the prenatal and postpartum period, and a few others that I'll definitely put on and give to you guys as well.
Perfect. Thank you. And we always like to mention that Postpartum Support International has a free helpline. Just Google PSI helpline. It's always available. So I think it's English and Spanish. So if someone wants to just have someone to talk to because they think this may or may not apply to them, then we highly recommend Postpartum Support International.
Yeah. And then just going to like your labor and delivery, like triage or the labor and delivery floor of your hospital too. So if you ever feel that you're, might be developing signs of severe or moderate postpartum anxiety, depression, and or psychosis, and or any condition, they're here for you. So really, healthcare professionals want you to seek out support, want you to know that there are resources available, and please reach out to somebody at your local hospital.
Great. Thank you.
Oh, I'm just so pleased that we got a chance to chat with you, Allie.
Thank you so much for having me.
You can subscribe to this podcast in order to hear more from us. Thank you for listening, everyone, and I hope you'll join us next time on the Fourth Trimester. The theme music on this podcast was created by Sean Trott. Hear more at soundcloud.com/Sean Trott. Special thanks to my true loves, my husband Ben, daughter Penelope, and baby girl Evelyn. Don't forget to share the Fourth Trimester Podcast with any new and expecting parents. I'm Sarah Trott. Goodbye for now.
Hello again, bicycle man. I know you're doing all that you can. I wrote the song, simple and true. I wrote the song, I'll sing a song for you. You got your wheels, you got your gears. You ride around town without any fear. You got your pedals, you got your brakes. You always wear your helmet for safety's sake. Hello again, bicycle man. I know you're doing all that you can. I wrote the song, simple and true. I wrote the song, I sing a song for you. Hello again, bicycle man. I know you're doing the best that you can. I wrote the song, simple and true. I wrote the song, I sing a song for you.